Welcome back to Clinically Clear, guys. Today we'll be covering trauma to the face. Now, when there is any trauma to the face, the most commonly fractured bone is, of course, which is the protruding one, the nasal bone. So first, let's look at nasal bone fractures. Causes trauma. So what happens? Patient comes to you with a lot of swelling, edema, redness, pain. How will you diagnose it? Will you take an X-ray? See, actually, in nasal bone, X-rays are not that useful in nasal bone fractures because the vessels and the suture lines of the nasal bone they are very similar to fracture lines. They appear very similar to fracture lines, hence they are not that useful. X-rays are only useful in such cases where there is displacement of the fracture fragments. Otherwise, X-ray is not very conclusive of a nasal bone fracture. The main way we can diagnose it is through crepitus. When we do this, there is crepitus, there is crackling sound because of the fractured fragments rubbing against each other. So diagnosis is by crepitus, but it is very painful. So hence most cases you will suspect a nasal bone fracture. Types of nasal bone fracture. First, let's do type 1 and type 2 nasal bone fractures. In type 1 and type 2 nasal bone fractures, there is fracture of both the nasal bone as well as the septal cartilage. Understood? Septum and the nasal bone is involved. Class 1 is a vertical fracture, 1 for vertical. So class 1 is a vertical fracture which runs upward. It is also known as Chevalier fracture. It is due to lateral trauma and you have very minimal deformity in class 1 fractures or Chevalier fractures. Whereas class 2 fractures, also known as Jarjaway fracture, is due to anterior trauma or it can also be due to lateral trauma. But there is way more deformity in class 2 fractures compared to class 1 fracture. There is gross deformity. Here the fracture lines, as you can see, they run backwards. So there is much higher deformity in class 2 fractures compared to class 1 fractures. Then coming to class 3 fractures. Class 1 Chevalier, class 2 Jarjaway. Class 1 vertical, class 2 horizontally backwards, class 1 less deformity, class 2 more deformity. Class 3 fracture is also known as naso-orbito-ethmoid fracture. This naso-orbito-ethmoid fracture, it occurs due to severe trauma, as in road traffic accidents, etc. When there is severe trauma to this region, you have naso-orbito-ethmoid fracture. What all can get fractured? The nasal bone can get fractured. The septum can get fractured. The dorsum of the nose is injured. The cribriform plate, the roof of the nasal cavity can get fractured. The laminae papyracea, the medial wall of the orbit can be fractured. So think of all the bony structures around here: the septum, the nasal bone, the lamina papyracea, the cribriform plate. All of them can get fractured because of severe trauma, high velocity trauma. And because the cribriform plate is injured, you will have CSF rhinorrhea. And such severe fractures, multiple fragments, you have to go for open reduction. So for class 3 nasal fracture, you have to go for open reduction. You have CSF rhinorrhea and class 3 nasal fracture. And remember something, class 3 nasal fracture, naso-orbito-ethmoid fracture, is characterized by something known as pig nose deformity. See, pig nose deformity is not the same as saddle nose deformity. In saddle nose deformity, there is depression of the dorsum of the nose. Here, just this part is fully depressed inside because of the trauma. It just gets depressed inside. So as you can see here, there is pig nose deformity. So this is pig nose deformity, not the same as saddle nose. Pig nose is seen in class 3 nasal bone fractures or naso-orbito-ethmoid fracture. As I said, class 3 nasal bone fracture, naso-orbito-ethmoid fracture, you have to go for open reduction. But class 1 and 2, the ones which are most commonly seen because of any fall or any object hitting the nose, the management is slightly different. How will you manage it? Basically, let's say patient presents with history of trauma with severe pain, swelling, and you see that there is crepitus and you diagnose it as a nasal bone fracture. Will you straight away go for reducing the nasal bone fracture? No, you will not straight away go to reduce it because of the edema, because of the swelling, you are not able to see the deformity, how much to realign, how much to reduce, etc. So what will you do? You will ask the patient to go home and come back after 5 to 7 days. By 5 to 7 days, what happens? The edema would have subsided. So once the edema subsides, you can decide what to do. Once the edema subsides, if there is no external deformity, then no treatment is required. Why? Because this part really does not have any function. It is just for cosmetic value. So no treatment if there is no external deformity. If the patient comes with external deformity, you have to go for which type of reduction? close reduction. Class 1 and 2 nasal bone fracture, if they have come back after 5 to 7 days with external deformity, always go for close reduction, as you can see in this picture. So how do you do close reduction? There is something known as disimpaction and realignment. Basically, using these forceps known as Ashe's forceps and Walsham's forceps. Ashe's forceps is for the septum. Walsham's forceps is for the lateral wall. So using Ashe's forceps and Walsham's forceps, as you can see here, the forceps is going and holding onto the septum like this, right? So what we do is we do disimpaction. Disimpaction is basically we refracture the nasal bone into small pieces. By refracturing them into small pieces, it becomes very easy to realign them. So we refracture, we disimpact them, and then we realign them using these Ashe's forceps and Walsham's forceps. Once we realign them, we hold them in position by using nose splint. So we give a nose splint for about 2 weeks to hold the realigned bones back in position and to allow for union. So this is the most commonly practiced way of close reduction, disimpaction and realignment, followed by nose splinting for 2 weeks. But let's say a patient does not come back after 5 to 7 days, but patient comes back to you with external deformity after 2 to 3 weeks. Then close reduction is no longer an option. Why? Because by then already the malunion would have taken place. The deformity would have been completely fixed. The bones would have healed in a very, they would have united in a improper way. So the deformity will not be corrected by close reduction. You cannot refracture and then again cause a realignment. So you cannot go for close reduction. If they come back after 2 to 3 weeks with external deformity, you have to go for open reduction. That is open reduction by septorhinoplasty. One important thing is this open reduction by septorhinoplasty you will only do if the patient's age is more than 17 years old. This is because all around the nose, nasal bone and the facial bones, you have secondary ossification centers which don't fuse before the age of 17. So if we go for any open surgeries, these secondary ossification centers could get damaged, leading to permanent facial deformity. So because of that, we always, let's say a child comes to you with external deformity after 3 weeks of trauma. Then will you go for open reduction? No. You will ask the child to wait until he or she turns 17 years old and then go for open reduction by septorhinoplasty for cosmetic value, of course. This is about nasal bone fracture, most common. Second most common is what? The tripod fracture. That is the fracture of the fracture of the zygomatic bone. This is the zygomatic bone. The fracture of the zygomatic bone is known as tripod fracture. Why tripod fracture? See, zygomatic bone is attached to the frontal bone by zygomatico-frontal suture, to the temporal bone by zygomatico-temporal suture, and to the maxilla bone by the zygomatico-maxillary suture. So 3 sutures. If all 3 suture lines you get a fracture, then it is known as tripod fracture. It is due to trauma to the cheek. So fracture of the zygomatic bone. Now the symptoms, think about it. Because of a trauma this way, the cheek, this eminence in the cheek, you can see an eminence here, right? This prominence or eminence is known as malar eminence. There is flattening of the malar eminence. There is flattening of the cheek. Number 1. Number 2, there is something known as trismus. What happens is because of trauma this way, trauma is coming this way, right? So because of that, what happens? The fractured fragments, they get pushed posteriorly. And when they get pushed posteriorly, they can impinge on the temporomandibular joint. If they impinge on the temporomandibular joint, it can restrict the jaw movements. This is known as trismus. So another symptom is trismus, restricted jaw movements. That is one more point. And another small foramen that I've circled here, as you can see, this is known as infraorbital foramen. This infraorbital foramen is where the infraorbital nerve passes through. And this infraorbital foramen and infraorbital nerve, it provides cutaneous innervation to the cheek. Now, obviously, the zygomatico-maxillary suture will also get fractured. So, this floor of the orbit, this whole region can also get injured. So, there is infraorbital anesthesia. Patient has anesthesia over the skin on the cheek. So that is the third symptom. Then zygomatico-maxillary suture forms a part of the floor of the orbit. So you will have many orbital signs like enophthalmos. See, exophthalmos is protrusion of the eyeball. When will that happen? When there is any mass behind the eyeball. But if there is trauma coming from the front, it will push the eyeball inwards. This is known as enophthalmos. Then step deformity of the floor of the orbit. As I'm palpating the floor of the orbit, suddenly I feel a step, I feel a discontinuity, a step-like discontinuity, that is known as step deformity. Why? Because of the fracture of the zygomatic-maxillary suture. Then because of the fracture there, you'll have edema, you'll have swelling, you'll have all that stuff. No, that will cause entrapment. It puts pressure on the extraocular muscles, mainly the inferior oblique and the inferior rectus. Why? Because it is at the floor of the orbit, right? So because of that, what happens? It restricts the extraocular movement only on one side. This will lead to double vision, diplopia. And most importantly, and not most importantly, another thing is periorbital emphysema. Because of the fracture, air enters into the orbit around the eyeball and there is periorbital emphysema. So, orbital signs, periorbital emphysema, enophthalmos, step deformity of the floor, and diplopia. How will you diagnose tripod fracture? When you do an X-ray or a CT through Waters view, you can see the fracture line. You can also see the displacement of any fractured bone fragments, etc. Treatment of tripod fracture is through open reduction with internal fixation by wiring. And this internal wiring fixation in tripod fracture is done at the zygomatico-maxillary suture and also at the zygomatico-frontal suture. So at two places you will do wiring fixation. You will do, first of all, you do open reduction, you will do open reduction, and then you will do internal wiring fixation at the zygomatico-maxillary suture and the zygomatico-frontal suture. This is about tripod fracture or zygomatic bone fracture. Then coming to another very important one, that is blowout fracture. See, when there is trauma to the orbit, let's say a ball comes in straight, falls on my orbit, directly onto my orbit, then which do you think is the most commonly injured bone, most commonly injured part of the orbit? See, lamina papyracea, the medial wall of the orbit, it is actually the thinnest part of the thinnest wall of the orbit, but it is not commonly fractured because of the ethmoid sinuses next to it acting as mechanical buffers or cushions it. So that is why it is not the most common. So blowout fracture is the fracture of the floor of the orbit. Very, very important. Floor of the orbit fracture is known as blowout fracture. Now, most common fracture due to trauma to the orbit is blowout fracture, fracture of floor of the orbit. Again, as I told, just underneath the floor of the orbit, you have the infraorbital foramen, infraorbital nerve that can get injured, leading to infraorbital anesthesia. Again, there is injury to the floor of the orbit that can lead to fracture of the floor of the orbit that can lead to step deformity. Enophthalmos, eyeball gets pushed inwards. Diplopia due to entrapment of the inferior oblique and inferior rectus. Periorbital emphysema. So orbital signs you'll have infraorbital anesthesia. Diagnosis, there is a characteristic sign known as teardrop sign when we do CT. Basically what happens, because of fracture of the floor of the orbit, as you can see the floor of the orbit is fractured, the orbital fat, it starts protruding into the maxillary sinus. This orbital fat protruding, slowly falling into the maxillary sinus appears like a teardrop. This is the characteristic sign. Treatment, once again, open reduction but via transantral route. Via the maxillary sinus you will go, just with a finger itself you can reduce the blowout fracture. So via the transantral route you will openly reduce the blowout fracture and then you will place a pack in the antrum to support the reduced fragments. Once you reduce it, you will place a pack in the antrum to support the reduced fragments so that they don't once again, because of pressure or anything, fall downwards, meaning get displaced downwards. So that is about blowout fracture, fracture of the floor of the orbit. Next, coming to maxillary fracture because of trauma to the maxilla or the upper jaw, also commonly known as Lefort fractures. Very, very important. Lefort fractures are of three types: Lefort 1, Lefort 2, Lefort 3. Now, Lefort 1 is also known as Guerin's fracture. Lefort 2 is also known as pyramidal fracture. Lefort 3 is also known as craniofacial disjunction. Basically, what happens in Lefort 1, the fracture line, as you can see, is parallel to the palate. It is parallel to the floor of the maxillary sinus and the floor of the nasal cavity. So fracture line parallel to the floor of the nose, to the floor of the maxillary sinus, as well as to the palate. So that is where the fracture line is. At this level, it runs backward. So what happens on CT scan? It appears as if the palate is hanging. It appears as if the palate is hanging from the rest of the face. So that is why it is also known as hanging palate. and there is no involvement of the infraorbital foramen, so no infraorbital anesthesia. There is no involvement of the cribriform plate, so no CSF rhinorrhea. So this is about Lefort 1 or Guerin's fracture. Lefort 2, also known as pyramidal fracture, the fracture line, it starts from the floor of the maxillary sinus, it goes to the floor of the orbit, then it goes to the lacrimal bone, it comes to the nares yawn, and then once again comes to the lacrimal bone, to the floor of the orbit on the other side, and then back to the floor of the maxillary sinus. That is why it has a pyramidal shape. So this is how the fracture line runs. So remember, it goes all the way up to the nares yawn. Nares yawn is somewhere near the roof of the nasal cavity. So roof of the nasal cavity is cribriform plate. Injury to the cribriform plate will lead to what? CSF rhinorrhea. So you do have CSF rhinorrhea because of injury to the roof of the nose. And also, it is going very close to the floor of the orbit, as you can see. What is near the floor of the orbit? Infraorbital foramen. So infraorbital nerve can also get injured, leading to infraorbital anesthesia. So you will have both infraorbital anesthesia as well as CSF rhinorrhea. Here the CT scan, it appears as if the entire maxilla is hanging. So it is also known as hanging maxilla. Lefort 1 is hanging palate, Lefort 2 is hanging maxilla. Now, Lefort 3 fracture is seen in very high velocity trauma like road traffic accident. Here what happens? The entire cranium is separated from the rest of the face. Hence, it is known as craniofacial disjunction or craniofacial dissociation. Here also the roof of the nose is involved. So here you will have CSF rhinorrhea. But infraorbital foramen is not involved. Hence there is no infraorbital anesthesia. So CSF rhinorrhea is seen, but infraorbital anesthesia is not. This is Lefort 3 only in high velocity trauma, craniofacial disjunction, craniofacial dissociation. So based on the fracture lines, you can classify maxillary fractures into Lefort 1, Lefort 2 and Lefort 3. Treatment is like most diseases, maintain ABC. Here airway and breathing you will check for, and circulation, what is important is maxillary bone fracture is commonly associated with maxillary artery injury leading to hemorrhage. So you have to control that hemorrhage as well. So control maxillary artery hemorrhage, airway and breathing. And it is of course a severe fracture, right? You can't do it closed reduction or anything. You have to go for open reduction with internal fixation. For Lefort, any of the Lefort fractures, you have to go for open reduction with internal fixation. Then mandibular fracture is not important. Basically, there is something known as Dingman's classification, where based on the prevalence of where maxillary fracture is most common, he classified maxillary fractures. The most common site is at the condyle, weakest part, condylar fracture. Why does it happen? Because of trauma from the opposite side. Basically, let's say I get punched from this side of the mandible. Then what happens? The entire mandible gets displaced towards this side, right? But the condyle on this side is located within the TMJ fossa. So the mandible is getting displaced, but the condyle is still stuck in the TMJ. So that leads to condylar fracture. So it is due to trauma from the opposite side. Remember always, condylar fracture on this side is because of trauma from the other side. Because the condyle on this side gets stuck in the TMJ, and whereas the mandible moves, mandible gets displaced. So therefore there is condylar fracture. How will you treat it? Open reduction with internal fixation by mini plates. Small mini plates can be fixed onto the fracture lines with screws, which eventually cause healing and allow for reduction. So this is about trauma to the face. I hope you guys enjoyed the video. Thank you for watching.